Good afternoon. I think we'll start, and people can come in as they are ready. My name is Santi, and I'm a pharmacist from Erlanger Pharmacy, formerly known as Moore & King. Our pharmacy, I'm from the Bedside delivery program. It's kind of like a meds to beds program. Our location is on the Medical Mall, first floor. Our store hours are Monday through Friday, 7 to 7, Saturdays 9 to 1. We deliver medication to the bedside weekdays from 8 to 7 at night, but we ask that prescriptions be faxed down before 5:30. And Saturdays, we can process the prescriptions in the pharmacy, but we don't deliver to the beds. So we have deliveries to the whole of Hamilton County for free. It's next day delivery. We even have people that are homebound where we go and collect the prescription at home, bring it to the pharmacy, fill it, and take it back to them the next day. So if you have patients that are homebound, you can offer that to them. Other services we have available is immunization services. We fit for compression stockings. If we don't have that stocking in store, then we can send it by FedEx next day or in 2 days. We have bariatric vitamins, and we do compounding. Things like hormones and troches and so on gets done at East. So what you'll do if you want the prescription filled with us is hopefully you'll ask the nurse or the case manager to fax it down to the pharmacy. They also need to call us to let us know something's coming, and then our technician will start to troubleshoot that prescription, see what the insurance is, if the insurance is going to pay for it, how much it costs. If they don't have any insurance, then we'll offer them our highly discounted 340B pricing. Things we look at are prior authorizations, coupons, if there are any free trials, like with all the Xareltos and Eliquis and those things. And then we'll give them their free first fill, and we'll also see what their copay is going to be next time. If they're indigent, we can probably set them up with the patient assistance program. So then we'll fill the prescription, and the pharmacist will deliver it to the room and counsel the patient. We try to get all this done within an hour and get the medicine to the patient, but what can help a whole lot is if you let us know pre-discharge that a patient is going to need, say, insulin or diabetic supplies, we can start to see what brands are covered, and that can speed up the process. We have really good prices on some of the insulins. If you want to give Novolog, Humalog, Levemir, typically that'll be about $280 at a normal retail pharmacy, and you can see what our prices are really, really good, around $15. So a good practice is if you have diabetic supplies that somebody needs, is to write that on a separate script. The reason is Medicare Part B can pay for that. Most of the times Medicare Part D, that's their drug coverage, won't cover those items. So if we want to fill it under Medicare Part B, then we're going to need a diagnosis code, the frequency of testing, and also the amount that we need to dispense. You need to get that on there. Lancets, alcohol swab test strips typically comes in hundreds. You can always write more and we can make less, but we can't add anything. The pharmacy can investigate what brand of insulin will be covered and what type of meters and so on can be covered. It takes a little while too, so if you do that the day in advance, that helps us. If we get a diabetic patient that's new and they just have a lot of trouble understanding, if it's within the first 3 months that they use Novolog or Levemir, we can get the Novo diabetes educator on board, and that'll be by phone, but they'll call the patient every week and they'll be available for questions. Set Medicare Part B sometimes has to cover the nebulizer solutions and diabetic supplies. So same for nebulizer solutions, always write it on a separate script, diagnosis code or the ICD-10 code, the frequency that it's used, that it needs to be used, and your quantity. Any refills written at discharge can get the special 340B pricing. So if you want to make sure somebody gets their insulin for the year, you can write 12 refills. Otherwise, they can go to the Dodson Avenue or Southside locations and get with a doctor there, or you can see them there, and they can get it at the same prices at the Dotson pharmacy. $4 drugs are available, same thing as at other stores and for discharge patients, so don't send them to one of the retail pharmacies for that. We have significant discounts on some really expensive medications like Lovenox, Levaquin, Zyvox, some antibiotics, some antifungals, some antihelmintics, and the insulin medications. Don't think that somebody has Medicare, that's TennCare, and that's why they can just leave and go fill it at any pharmacy. There's a maximum of 5 items per month that they can fill on TennCare. Items that are maintenance medications should not count towards the 5, but sometimes we have to call the insurance and remind them about that. We can also see if they have several items, we can see which are the cheapest ones and put that on $4 and just fill the expensive ones on their TennCare. Now this one is the narcotics and controlled substances. They must be filled in Tennessee to guarantee that they're actually going to get it. The prescriptions written by physician's assistants, nurse practitioners, and residents cannot go out of state. You have to get your attending to sign those. Georgia Medicaid we can fill here if your attending signs it and if they are contracted with Georgia, which most of our attending physicians are. We have a problem with prescriptions going to Alabama or North Carolina for Medicaid because we don't really have any physicians that are contracted with them, so just tell them to fill it in state. One more thing is since July the 20th, TennCare will only allow a 7-day supply of narcotic medication for an adult that gets a first fill. Same with kids, but you mainly see adults. So, any questions? Okay, thank you.
I'm Paul Smith. I am the Care Transitions Manager, and I am going to go over with you about the Care Transitions program we have here at the hospital. What is Care Transitions? It's a program that has been formed to meet and exceed CMS changes from the Affordable Care Act. In 2010, they made a bunch of changes, and it has to do with being fined for patients, hospitals being fined for patients who are readmitted with certain diagnoses, and there's 2 different kinds of fines. One for the diagnoses, and that is a financial fine, and then there is the star rating. And the star rating is where hospitals are told if there are 1-star, 2-star, 5-star being the best, 1-star being the worst. And so we want to be a 5-star and not a 1-star. And right now Erlanger is almost a 3-star, so we are a 2-star right now. Purpose of the care transitions, we're going to talk about what the purpose is and what insurance does include. The purpose is to decrease the overall readmission rates for the Medicare fee-for-service A and B population. So the Care Transitions program is only focused on patients who have Medicare A and B, not Medicare Railroad, because that is excluded because it's a whole different subsystem. Medicare C is excluded, and any Medicare Advantage plan is excluded because none of them are fining us. It's only Medicare A and B that are doing the fines. Hospitals will be fined for readmissions within 30 days for congestive heart failure, heart attacks, pneumonia, COPD, joint replacements, those are the total hips and total knees, and cabbages. And so if a patient is in the hospital, and it doesn't matter what they're admitted for, it only matters what they're discharged with. So if they are discharged with congestive heart failure, and they go home, and 2 weeks later they trip over their dog, and they fall and break their arm, have to come into the hospital and have that fixed. That counts against the hospital. It doesn't matter, again, it's not what they are admitted for, it's what they are discharged with. And so you have to keep these patients out. So when we look at discharging, we're not looking at just the diagnosis. We're looking at the patient as a whole. We're looking at their comorbidities. We're looking at how many times they've been in the hospital in the last year. There's a lot of things that we look at, and then we communicate with the doctors to help you understand. We see them coming back within 30 days. We might need this. And so we might be talking more about hospice, or we might be talking more about palliative care. So there's different options and different opportunities, but we'll talk about that here in a second. So how do the fines work? The way the fines work is every year we get a fine, but it's always 3 years back. So when you look at 2011, when we got our fine, that was the first fine that came out. It went from July 1st, 2008 to June 30th, 2011. That was a 1% payment. And so what that means is, let's say you're only allotted 50 readmissions, and we went over 50. So they'll take those 50 patients that we went over and add up their bills, and then what happens is we pay 1% of that bill. But we don't write a check. What we have to do is, so every patient that comes in for the following year, we actually make less on them. So let's say the bill or the payment would be $1 million. Let's just say that. And what they would do is, if a patient comes in and they pay $2,500 a day, they're only going to pay $1,500 a day until that $1 million is paid off. So they'll calculate how many patients you normally get, and then that's how they do it. So we actually make less money. And so with less money, we have a hard time doing other things because you want to do the full care for them. And so we really want to pay attention to that. Well, in 2013, it hit 3%. And it's staying at 3%. But what they're doing is they're adding more diagnoses. So cabbages were just added this past year, and COPD and total hips, total knees, this in 2014 was the first year we actually received if we're going to get fines or not for them. And so we have to be careful on those, and so we'll be communicating a lot with you all on that and how to keep the patients out. We have a program here, and I'm going to talk about the parts of the program, the call center versus the Erlanger's Care Transitions Team, because we have to follow the patient for 30 days once they're discharged, because the thing is you have to keep them up for 30 days. Day 31, okay, does that mean, yeah, woo, we're okay, we kept them out, this is good, they come back, we're not going to get a fine? Well, in the next couple years, they're changing it to 60 days, but they possibly might change it to 90. And so that means you have to keep these patients out for 60 to 90 days to try to not get a fine. And so, so we have changed some stuff, and you'll learn that here in a second. So who qualifies for the Care Transitions Program? Any Medicare fee-for-service A and B patient who is 65 and older. When you look at that and you think, wow, but a lot of the patients I see really aren't. We, last year, we have saw and followed 6,300 patients. And those are the patients that were Medicare A and B, 65 and older. So we do get a lot of patients, quite a few that have Medicare. And that's only, and we're like about 45% of our patient population is Medicare. And so that's quite a few. We also have a focus on the congestive heart failure, heart attack, pneumonia, COPD, total hips, total knees, and then, of course, cabbages. And then with extra focus on any readmission within 30 days of discharge from the hospital. And these are all the Medicare A and B patients. The call center will follow those patients who have those 6 diagnoses. And also they follow anybody that was readmitted within 30 days. So they will pick those patients up and follow them and help them. They provide 3 calls, and it doesn't matter where the patient lives, as long as they go home. And so if a patient's here on vacation and they live in Michigan or they live in Florida, we actually will call them 3 times and follow through, because what happens is you're trying to keep them from being readmitted. So let's say, even here in Chattanooga, you have a patient who comes in the hospital and they are discharged, and they have COPD. 3 days later, they're having issues, and they went to Park Ridge. What happens is we just got dinged because they got readmitted to another hospital. Doesn't matter where they get readmitted either. Medicare knows where they're at. Big Brother will follow you. And so their eyes are big and they know exactly what goes on. And so we follow them to try to, if they're going to be readmitted, we encourage them to come back here if they're close, so that we can fix it. Maybe put them on observation versus a full admit, because if someone is under observation, it doesn't count as a readmission, and so that saves us. The first call is within 48 hours after discharge, and yes, they do calls on Saturday and Sunday. What they do is they will call the patient and they'll go over the discharge orders with them again. Make sure that everything that was promised from the hospital side really happened. Did home health contact you? Did you get your prescriptions filled? Is everything going the way it's supposed to? Are you feeling better? Are you feeling worse? And they try to ask questions and make sure if they go home with a breathing issue, they ask questions about that, and they triage every problem that they're discharged with. The second call is within 10 days after the first call. What they do at that time is, how are you doing with your medications? Is everything going well? How was your follow-up appointments? What did the doctor say? Is there any questions that you have? Have you developed any new problems? And then third and final call is 15 days after the second call. And that's very similar to the second call that we do. But what we do is we also congratulate them if they completed the program and say thank you for doing your part and staying out of the hospital. We appreciate it. If you have any questions, they can call us and follow up. If a patient goes to a sniffer rehab, those facilities, and this has just changed last month, those facilities are now having their own care transitions programs, and they have to follow those patients now and keep them out. So if a patient goes to a sniffer rehab and they're there for 2 weeks and they go home, and then 3 days later they end up being readmitted to our hospital, what happens is we actually ding the nursing home or the rehab hospital. It actually counts against them. The goal is for them to reduce their readmissions also. If they have over a 25% readmission rate, then we actually will talk to that facility and let them know that we might not make as many referrals or any at all, because we need to try to help the patient be safe and go to a place that will help them stay out. And so I have a meeting with them every month. They come to these meetings, they know where they're standing, they know how they're doing, and we haven't really had to put anybody on that probation because they've all been coming to the meetings and doing what they're supposed to be doing, so that's a plus. The care transitions team, they're calling it the Medicare SWAT team. Yesterday was our first day. So before yesterday, for 4 years, I did this program by myself. The call center actually helped me do the calls, but I see every patient. When it's over 6,000 patients, that's a lot of patients to see. So sometimes I have to assess them after they're discharged, and I have to call them and offer them the program and make sure that we met all their needs and everything. And it got pretty rough. But now I have a team. Carolyn Bradley, Kelly DiPaolo, and Diane McLaren are now on the SWAT team. And we focus on the Medicare patients on trying to help them, because what we're doing is we train them and we're looking at what keeps them out, not just getting them out. Because yes, we need a bed, we need to get them out, but then we're also looking at what's going to keep them out. And so we're going to talk about some of those things here in a second. I don't know what I just clicked. Okay. What we do is we provide case management, discharge planning for all these Medicare fee-for-service patients who are 65 and older. The case managers are not doing it anymore because we are case managers, because we work in the case management department, but we are the ones that do it. So we actually cover more than one floor. And so we're throughout the hospital looking at all these Medicare patients and trying to help them. And again, to focus on the safe discharge, but keeping the patient out. And we focus on how many times they come back. If we notice a patient, per Medicare guidelines, if a patient has been in the hospital twice in 1 year, that's a chronic admissions. So if you have a patient that is readmitted, they automatically hit chronic admissions at a hospital. So we have to be careful because they look at that, and that's one of the tools that they use to try to see how many dings we're going to get. And we also use a LACE readmission tool. We started that in June. This LACE readmission tool, what it is it's done through the computer system, and it, I think I have the next slide, yeah. It stands for length of stay, and it's the length of stay of this admission. So that's going to change. So they might get 2 points for the length of stay, but tomorrow they might be at 3 points, and it will go really quickly depending on how long they're here. A is acuity of admissions. Were they admitted through the ER or not? If they were admitted through the ER, they get more points. A lot of our patients get admitted through the ER. C is comorbidities, and the reason why is because the ER could have stopped the admission, hopefully. And then C is comorbidities. They look at all these comorbidities that they have, so they look at the history of that patient. And then E is the emergency department visits. If they have more than 3 ER visits in 6 months, it shoots them up to 8 points really fast. And so some people will be like, as soon as they're admitted, they might have 24 points. They're considered low risk if they score a 1 to 4. They're considered a moderate risk if they're scoring a 5 to 9, and a high risk if they score a 10 and above. This is the key factor for you all. Anytime, because when we chart on these patients, we put what their score is, their LACE score. And anytime someone scores a high, and if they go home, they should not go home with anything less than home health. And when they go home with less than home health, they start saying, well, did you neglect this patient? Because you knew that they had the possibility of coming back. Did you really do everything you could to help them? And so we need to start looking at those. And so that's why we're doing this score now, because we want to protect ourselves, but we also want to protect the patient. Because sometimes you look at a patient, like for me, for instance, I talk normal. I look normal, but I'm actually deaf. I have no hearing in one ear. I have 70%, and it's going down because it was at 90% 2 years ago. But I have 70% hearing in my left ear. And so I'm losing my hearing quickly, but it hasn't affected my voice. So when you talk to me and I'm looking at you, I read your lips very well, but also can hear pretty good with the other ear. It just depends on where I'm standing. But when you look at patients, sometimes you're like, oh, they look fine. They're walking and talking. They don't need home health. But if we make the home health referral, let home health come in and assess them, they can decide if they really need home health or not. They can be a part of that. And we actually boosted up our home health referrals, and we're going to talk about that here in a second too. But a lot of times, we don't know the difference between hospice and palliative care. Recently, I've been talking to doctors saying, I really think this patient needs palliative care. Paul, the patient's not dying. Didn't say they were dying. I said they need palliative care. Let me tell you the difference between hospice and palliative care. Hospice is when a patient has been guaranteed 6 months or less to live. And when you look at that, if the patient goes home and they don't take their medicines, they don't do what they're asked to do, they don't follow any of the instructions, do you think that person will live for the next 6 months? If the answer is no, then that is a hospice consult. A palliative care consult or a palliative care is more chronic disease management. If a patient has 3 comorbidities, CHF, COPD, and they have hypertension issues, those are chronic illnesses. Palliative care can get involved and help them manage it better, especially if they have multiple readmissions. And those are the things we look at. And so What we're looking at is how many times has the patient been admitted in the last 6 months, how long has patient had chronic illness or disease, has patient been gradually declining in the last few months. For CHF, if the ejection fraction is below 30%, it qualifies them for hospice because their ejection fraction is so low. If it is between 30 and 45%, that actually qualifies them for a palliative care consult. And also, what is their oxygen use? If they are on anything above 2 liters of oxygen and they have to have any kind of assistance for anything, that is also a palliative care consult because they're not able to be truly independent, even with the oxygen. The need to involve hospice sooner with chronic illnesses versus waiting for death's door come knocking, we have issues with that. Something I'm also going to let you know that if you ever see an order or you write an order that says, because we're not just part of the readmissions team, we're also part of keeping, when patients die, we're over that too. And so so if you write an order and you put a patient on comfort care measures, you're probably going to get a call from me. Comfort care measures doesn't mean anything except the patient's dying. So if a patient is dying and they have hospice, then Medicare, CMS, will look at us and say, you recognized it and you put a solution in there. You just didn't put them on comfort care measures. If a patient goes to a nursing home on comfort care measures and they die, it counts against our mortality rate. And so we have to be careful. A lot of times we think we know what's best for the patient, but also if we really want to do what's best for the patient, we also will think of the family. Anytime someone's on hospice and they die under hospice, the family can get counseling for the next year to year and a half. They receive services from the hospice people to help them deal with the death. Sometimes when we put someone on comfort care measures, they don't have anyone to turn to help them with dealing with that death. If my wife died today, I would have a very hard time for the next year and a half or longer because I have 6 kids. That's a lot of kids. But so I would want something to be able to help me deal with her death. Does care transitions work? Does anyone have any questions about palliative care or hospice? Wow, you guys got lots of questions. It's great. But speak up. Don't be afraid. I'm not gonna bite you. So let's see if care transitions works. In 2010, you can see all Medicare patients that we had that were 65 and older that had A and B, we were at a 13.2 readmission rate, and that was for all of them. In 2015, we were at a 12.1. We've reduced it, and in between, we kind of bounced a little bit. When you look at AMIs, we were at 11.8, and we went down to a 9.7. In 2014, we were at a 3.9. And so how did we get down to a 3.9, and in 2015, went up to 9.7? There was something different about 2013 and 2014 that the overalls were kind of lower than the rest. Does anybody want to take a guess why they think that was? And I'll give you a hint. It has to do with the flu shot. The strains weren't right. And so there were a lot more people who were sick with the flu. And flu can actually exacerbate a lot of these illnesses. And so we just started getting a lot more patients because the flu strain was not right. And so CHF, we went from 12.5 to 16.1. We climbed. COPD, we went from 10.3 to 14.7. We climbed. And pneumonia, we went from 21.2 down to 10.9. We have received 2 fines since this has been going on. We received a fine in 2011, and it was a really small fine. The hospital It was like a $45,000 fine. That was over the CHF patients. In 2014, or I guess 2015, because we just received that fine, we also received a small fine, and that was for the COPD patients, and that was also for our total hips and total knees. The total hips and total knees has a program now that we're really working hard on those patients, keeping them out, and we are reducing. One of the issues that we had was some of the equipment that they were using. We figured it out, we fixed it, changed it out, and also the cleaning of the utensils. For a while, they didn't realize the thing was broken, so they fixed it. And so it wasn't cleaning the utensils as much as it needed. And then also, so we also changed some of the medications that patients were on to help keep infections down. Most patients were getting the same medication and the same dosage. And one of the things that we learned was a 35-year-old and an 82-year-old heal differently from the same surgery. It's harder for an 82-year-old to heal because they're more susceptible to things. And so we changed that when they were discharged, and we upped their dosage, and it reduced their readmissions. And so we start looking at all these things. So far, yes, my job is very busy. And me being the only one doing it and looking at every readmission and looking at every patient that came in the hospital was pretty hard. There's 4 main reasons why people are readmitted. Did not get prescriptions filled or understand how to take prescriptions. Did not have a follow-up PCP appointment or able to keep the appointment. Did not understand discharge orders or given a copy of the discharge orders. And the final one was discharged too early. So we came up with solutions. We fixed these things. Erlanger Pharmacy, they are encouraged to visit each care transitions patient who's being discharged home who have Medicare A and B, 65 and older. We notify them. We let them know. We tell them. We actually did a pilot on 4 units, and they knew every Medicare A/B patient 65 and older. I would give them a list, and they would go and they would see these people. We decreased readmissions by 12%. So we did a really, really good job on those people, because some of those people were not. They were also, they weren't not straight Medicare. So we looked at a whole bunch of different things. But we really did a good job, and we really helped. And it was a great turnout. The other thing about using Erlanger Pharmacy to help us is they can determine if any scripts need pre-authorization. Not every insurance is the same. And even with the Medicare, sometimes some things are pre-authorized for some people, but not for others. Some people can get away with it. And so if they are aware of the patient, they can check if these medicines need a pre-authorization. If they need a pre-authorization, they can do it within 6 hours in the hospital, hopefully. If a patient goes home and goes through their own pharmacy, it can take up to a week. If it's a life-saving medication, and they go home without it for a week because they're working out that pre-authorization, we just did a disservice for that patient. Possibly they could die. And so Erlanger Pharmacy knows how to push that, because when the patient's in the hospital, they can tell the insurance company they're getting ready to be discharged, so they can push it along quicker. They also help determine if they can get it cheaper, like antibiotics and all the things that Santi talked about. They can identify med programs that can assist the patient. And there are programs out there for Medicare patients that only make so much money, and that can help them educate patient on the meds, assist in determining if any meds interact with each other. This is something that a couple years ago, and it happened 3 patients in 1 month. And what happened was, we're a teaching hospital, and most of the patients have more than one doctor looking at them. They might have a cardiologist. They might have a hospitalist. They might have a nephrologist. They might have, there are more doctors that are looking at them. And one doctor wrote one medicine for this one medicine, and another doctor wrote for this other medicine. You combine those two medicines, it would have killed the patient because you can't have them both. And so the pharmacist, actually one of the liaisons, went to the floor because they had a list of patients, and they went to the floor and they knew this person wanted to have Erlanger Pharmacy help them. So they looked ahead and said, oh my word, they figured it out. We actually had 3 patients that month that had that. It was so weird. But we were able to fix it. And so hopefully we don't have those problems anymore. And then also, an MD can write an order for Erlanger Pharmacy referral. So if they find out that a medicine is cheaper, they can call you and say, hey, this medicine is cheaper than this one, and it's the same thing, and it tends to do the same thing. Do you want to change that? And then they can fix it, and to help that patient. And also, Erlanger delivers medications to Hamilton County residents and SNFs and rehabs. One of the things they didn't tell you is they're working with Health South, right? They're working with Health South, and Health South's patients actually get their medicines delivered before they go home. So it's part of what they're doing. They come to these meetings and they figured it out, and they were like, ooh, we want to do that. We also have a SNF is working on that also. And so we're trying to help all of these facilities, when they send their patients home, have that same opportunity that we do to get those medicines in hand. Solving the PCP issue. Case management assists with PCP, making sure that they have one. And then we also have a clerk that is helping us now, started yesterday, making all the appointments for those patients who are going home so that we can try to have that. Back in April, we also started just having the case managers make those appointments. And we went from, in such a short time, we went from 12%, because we had 12% of our patients getting a PCP appointment made before they left, up to 50%. And so we increased it. So all of our Medicare patients started getting appointments. And so that was a true blessing. And it was helping keeping patients out. Here it says we went from a 23%, this because the 12% was before we started in April, and when we started in April, we got up to 23%, and then when we finished in June, we were at 50%. If you write an order and you put see doctor in 2 to 4 weeks after discharge, that's not a PCP appointment. That's a recommendation. Try to get the clerk, because we only do PCP appointments, but if they need to follow up with other doctors, that clerk needs to, or the nurse needs to know when that appointment needs to be made so that they can make it, so that they can put it on there. Because if you're only making a suggestion, it's just a suggestion, it doesn't save us from being fined. Another thing that you might want to know is any Erlang or any doctor's office, if they can also make money from these patients. If they help us keep a patient out, they can make $250 on each patient. And so all of the Erlanger PCPs and doctor's offices, they're in on it. It's not a choice anymore. They're all a part of it. And so they get to make money off these patients. They can help us reduce the readmissions. But the kicker is that patient has to be seen 7 days after discharge. So they have to be seen within 7 days. Not 7 business days, 7 days. They count the weekend, even though they don't make appointments on the weekend. And so, so that helps us a lot. I'm keeping these people out. Care transitions clinics. We have a clinic now that's on Fridays, and it is in the AIM clinic. And what they do is the hospitalists actually are the ones that are in charge of that. And so Dr. Alvarez actually sees patients on Fridays to help them if they don't have a PCP, or if they can't get into their PCP soon enough. Then he will actually see them in his clinic and send that information to their new doctor. Also, SNFs and rehabs, they'll make their own appointments, and they're doing a lot better than they used to. Solving discharge instruction problem. The call center goes over discharge orders again on the first call. Plus, they will send them a copy of their orders if they don't have it. So they can mail it, because it's not a breach of confidentiality or anything, because they already were supposed to get a copy anyway, so it's theirs. And then solving discharge too early. Since we see all these patients, I review the chart fully and review information sent from the SNFs and rehabs as well for every patient that is readmitted within 30 days. And then I also assist the case managers, assist the doctors to come up with a better plan. So for instance, we had a patient that went to a rehab hospital, and within a month, they were admitted 3 times. So I went, talked to the family, talked to the patient, and asked them if they were happy there. Do you feel like you can do the therapy? Do you feel like you need to go to a skilled nursing facility? Explain to me what you feel like you need. And then they told me, and we ended up sending them to a skilled nursing facility, because the patient felt like they could not keep up what they wanted them to do, and they just kept getting sick and more sick. And so we were able to change it. And then the patient was very successful. They stayed out of the hospital. They haven't been back. And so it works. And then also we look to see if they're a hospice candidate or a palliative care candidate. And then home versus home with home health. We already talked about anyone that's a high. Try to get them home health as soon as possible so that they can, when they go home. But also, we have just increased our home health referrals, because we actually increased about 62% of our patients were going home without it. And then we are going home, without it. And then now we're at 84%. So, or 84% 6 months ago, and now it's at 62% that are going home without it. So we're improving. We're making more referrals. What qualifies a patient for home health? Nursing and PT can stand alone. So if they only need physical therapy to move around the house a little bit, but they don't really need skilled nursing, they can get it. If they just need skilled nursing, they can get it. Also, education of disease, education of med orders, need to say disease management and medication management. If you say disease education and medication education, well, you can do that. You can educate them on their medicines. When the pharmacy goes and sees them, they can educate them on their medicines, because they're going to say the doctors can educate them on those medicines. But you want them to be managed, because some of those medications have to do with a diet. They might not be able to eat certain foods with those medications, or they might not be able to do certain activities. And anyone with COPD or CHF should have a home med telemonitor. And a home med telemonitor actually is a free thing from the nursing homes. That they don't even bill their insurance company. And what it does is it monitors their vitals, and if they have CHF and COPD and they're on oxygen, then they can put an attachment on it and check their O2 stats on a daily basis. And if they have CHF and have a weight problem with that, they can also be weighed every day on it. And then keeping patients from being readmitted 30 days. What about patients who go home after discharge? Again, we call those, but if they go SNFs or rehabs, they're really working hard with me on this, and they're really reporting back, and it's really helpful. When we started 4 years ago, it was a nightmare, and so, but it's getting a lot better. I mean, it only took me 4 years to get help, so, woo, that's good. I'm making some progress. And this is my contact information. I also have my cards back there. If you feel, one of the things I really want to help you understand is, do we really help these patients? When a patient if we don't feel like they need home health or need a sniff or whatever, and we send them home with no needs, and we're following them, we actually will send the patient. We can actually send patients from home to a sniff, to a rehab, and also we can get them home health. We just have to go through their PCP. And so we have to educate the patient on how to do that. This is what you need to do now. This is how we take care of it. So sometimes we don't see it and we do miss it. But when we have issues and we see that it's a certain doctor or a certain case manager or somebody that keeps doing it, then we actually educate them and we pull them aside and we talk to them, help them understand. We don't want you to have a bad rap for your readmissions either. And so we want to be able to help you with that. We had a patient that, this was probably about a year ago, and he, pharmacy kind of probably will know who I'm talking about, but he was really bad congestive heart failure patient. And he was somebody that just did not, sometimes I don't want my medicines, you bring him his medicines, he starts freaking out and everything, but he kept coming back to the hospital. And so one day I was in there and I was talking to him and I asked him why. Why do you keep coming back to the hospital? Well, it's because you guys care about me. I can get meals, I can have this, and da-da-da-da-da, and I'm lonely. And so we started figuring out, wow, okay, his is more the social aspect. It's really not what was really the problem, but it was the social aspect. So what we did was we actually found out, because he came in one time for food poisoning, and then he came in one time because his air conditioning wasn't working. So I actually did a visit. I went to his home and I actually found out that the reason why his air conditioning wasn't working is because he didn't have air conditioning. In the state of Tennessee, you only have to sell a home. If you rent a home out or sell a home, they only have to have heat. They don't have to have air conditioning. And so, which I didn't think was fair, but we called the bureau and figured all this stuff out. And so we ended up buying him the hospital actually bought him one of those that you stick in the air conditioner, you can stick in the window and kind of cool down the house a little bit. So we got him one of those. Also found out his fridge, his outlet wasn't working. He really was getting food poisoning. He really was getting sick. So we fixed all these things and we started helping him. And all of a sudden we noticed he started decreasing his readmissions. We started meeting his needs. We started helping him. And that's really important when you guys assess a patient. Don't just assess why they're sick. Assess the whole patient. Because you will find out things about them that you probably would have never thought that could actually be a bother, a problem, or a bother to them getting better. There's a quote from Walt Disney that I really like. You can dream, create, design, and build the most wonderful place in the world, but it requires people to make a dream a reality. Care transitions can't do it alone. We need each other. I reached out to pharmacy and they helped me. I reach out to home health and I reach out to these SNFs and rehabs and they help me. I reach out to the doctors and they help me. It is us together as a team. If we are not a team, then then we have to question who we're really fighting for. And so a team has to fight together to really help these patients. When we reduce readmissions, we increase raises. We get opportunities for other things. Without that, we don't, we go without those raises and we get miserable and we can't hire other people. And that's why I'm finally glad I get help. I was able to prove my worth. They were able to see the things and we were able to get the help that we needed. Does anyone have any questions? Comments? Concerns? Wake up. All right. If you have no questions, thank you for your time. Also, you have a blue piece of paper, I think, that you're supposed to just put all 5s on there.